Dr. Zoghbi is the Elkins Family Distinguished Chair in Cardiac Health, Professor and Chairman of the Department of Cardiology at the Houston Methodist DeBakey Heart and Vascular Center. Dr. Zoghbi is a renowned leader in cardiology, cardiac imaging, and global health. He has developed new techniques to evaluate heart function and valve disorders without resorting to invasive procedures. Dr. Zoghbi is past president of the AASE and the ACC. He has served on more than 10 AASE committees and has chaired several AASE guidelines on valvular disease. He is involved internationally in cardiovascular health advocacy and health promotion. He has served on the board of the World Heart Federation and co-chaired the Global Task Force for Cardiovascular Disease for the World Heart Federation. It is our pleasure to have Dr. Zoghbi with us today.
Thank you, Liz, and hello, everyone. It's a pleasure hosting this webinar, and I'm glad that you're joining us today. What I'd like to do in the next 45 minutes or so and have some questions answered is to go over the recent guideline that was published in JACE in April of 2019. And it addresses a very important question that the clinicians and certainly the echocardiographers and imagers are trying to grapple with, which is evaluating valvular regurgitation after some of these wonderful new procedures that have come along over the past few years, percutaneous valve repairs or replacement. And if you look at the field, this is probably among the most exciting fields in cardiology nowadays. Over the past, I would say close to 10 years, newer developments of valvular heart disease that benefit really patients and involve not only the cardiologists, but certainly the imagers, because they really work as a heart team in the catheterization laboratory and afterwards to try to find what is the best diagnostic modality and see if the valve is functioning well, if the repair is functioning well, and if there is residual regurgitation, how much is that? Having said so, it really adds to the complexity because these procedures are not your regular procedures. They're not native valves. So either the hardware or the intervention has changed the way we evaluate with echocardiography valve regurgitation. So what I'd like to do today is emphasize predominantly aortic and mitral. We'll touch upon pulmonic as well as tricuspid, which is an evolving field, and hopefully have some questions and answers towards the end. So this is the guideline, and I don't know if some of you had the chance to take a look at it. I would encourage you to go beyond just reading the title and going inside, because it really provides a wealth of information. And I want to thank the American Society of Echocardiography, our collaborators, SCMR and SCAI, as well as all the members who were involved in putting this guideline together. So, and this guideline is not standing by itself. It really taps on two other guidelines that we recently published. One actually almost 10 years ago, which is still quite valid, is on prosthetic valves. These are the surgical approaches to prosthetic valves and their evaluation. So in the current guideline, we're not looking at evaluation of function. We're looking at evaluation of either residual or new regurgitation that occurs because of the intervention. The other guideline that I hope by now you've had a chance to take a look at is the one evaluating valve regurgitation of native valves. And the principles are really the same. So what is different is really depends on what is the valve itself, or the implantation of the device alters some of these, which at times can make it challenging, and we'll go through that through the presentation. So what is covered in this new guideline is the assessment of new aortic regurgitation after TAVR. And I would differentiate that from the other valves, because currently the other valves are to lessen the degree of regurgitation, be it mitral valve, pulmonic, or even tricuspid. So in the TAVR world, at times we may have some residual regurgitation that may not have been present because of aortic stenosis. And I know we'll tackle when some of these applications occur for native aortic regurgitation, which is in evolution now. I think that would apply to it. Also, we have to acknowledge in this guideline the limited parameters that you could use during the procedure, because echocardiography is the first line imaging modality in the catheterization lab or in the hybrid room. And you may not be able to do all the parameters that we usually use. So you have to decide of what are the ones that are very helpful and available. Third is the transthoracic evaluation, just like in native valves, would require an integrative approach because not a single modality, not single parameter can tell you about the severity of regurgitation unless you're dealing with a classical case. And last but not least, where does TEE and CMR fall into this equation? Few words about TAVR. It is certainly now an accepted alternative, and the latest trials of even low risk are very promising, actually quite impressive. Shortly, most likely we'll have an indication for that. Higher incidence of paravalve regurgitation compared to TAVR, which is the surgical aortic valve, and that is well acknowledged in the literature. The residual AR severity is predictive of outcome. And it has been a major impetus for improving valve design with skirts or different designs to decrease this paravalvular regurgitation, which currently is down to almost 0 to 2% of significant regurg. And the contributing factor, I think from an imager, it's important to think about them when you evaluate regurgitation is valve calcifications that were present, maybe the ones that are focal or the burden of them. Valve undersizing will cause regurgitation as well as changes in valve design. Another thing that is important for you to remember is there are some differences, not only from a mechanism, but also from imaging point of view of TAVR versus SAVR, the surgical implantation. In TAVR, you have multiple sites. And because of either a tiny malapposition or more malapposition because of calcium, whereas in SAVR at times there is a dehiscence of a suture line where most of the time it's localized in one area. The designs of the valves, the valve itself is within a cage, a relatively long metallic cage. So from an imager point of view, you have to take a look and scan throughout the valve to try to decide where the actual origin of the regurgitation is, and it is challenging. So therefore, from an echocardiographer point of view, this is very important. And remember that you still have native aortic valve in the TAVR procedure. Calcifications may hinder the apposition and alter the course of the regurgitant lesion, eccentric, serpiginous, and you have a little picture there depicting the multiple sites where some of these regurgitations occur after a TAVR procedure. This has the issue of should you do a transesophageal or TE during the procedure in the catheterization laboratory. I think it's rather settled now. Initially, it used to be under general anesthesia. Now I think most people have evolved into doing some conscious sedation and transthoracic echocardiography, not in 100% of the cases. And at times you may change from the transthoracic to the TE approach. In our experience, maybe about 60 or 70% of the time transthoracic. There are some labs that are still using predominantly TEE in these situations. But the considerations come into play are one, intubation of a patient, the resources used, not only monetary, but also personnel, image quality, continuous imaging with TE as opposed to periodic with transthoracic, echo imaging windows that may be available, the radiation, the shadowing of the aortic regurgitation from the prosthesis, depending on where the imaging is from. And this is also has been described in the guideline. Take a look at the transthoracic on top versus transesophageal on the bottom. Because of the prosthesis, you're going to have some shadowing. And since you're coming from the surface, this is posterior shadowing. So shadowing is not only for imaging, but also for color Doppler, as opposed to TE, where the shadowing is mostly anterior because you're coming from a posterior structure. So when you're in the cath lab, for example, or even in the surface echocardiogram, an apical window at times may reveal the regurgitation that you may have missed because of shadowing or not being in the plane per se. So a few words about imaging during the procedure of TAVR. This is part really of a team where the interventionalist is working closely with the imager. And this is transesophageal in this case that I'm showing here today. You can see where the regurgitation is paravalvular in this situation here. This is the larger one. This is a very small one. Quite impressive actually from the apical window. And you could use 3D to measure the Vena contracta area. Now, the aortic flow, for looking at reversal of flow in the aorta, and you could use that in the arch or descending aorta from the transesophageal approach. As you know, normally you could have a brief diastolic flow reversal. At times it can be a little more impressive in hypertension and the elderly. But I think it's important to get a baseline before you do TAVR to see how much of a change there has been. It doesn't take much time from the echocardiographer, and I think you'll be sitting on more solid ground to evaluate, the change in regurgitation or the residual regurgitation that has occurred. Not infrequently, where you have intermediate cases or you really cannot assess, I think there is an integrative approach of hemodynamics, where using the AR index or its modification also supplied in the guideline, as well as the aortography. And I think the more confident about you are, you may use less aortography. But I think, in situations where further intervention is needed in the lab, I think it's very important to do that. So in the laboratory, therefore, color Doppler is going to be very essential, and paying attention to the views, how you acquire these data, where the actual site is of the regurgitation, and using some aorta flow to look at reversal of flow in diastole, I think would be very important. Now, these are the several parameters that we look at, even in native aortic regurgitation, but there are some modification in this realm of TAVR. You always like to see what is the mechanism of the regurgitation here. Is it because of position of the prosthesis? Is it too high? Is the stent deformed because of calcification? What's the leaflet morphology, particularly later on? Color Doppler, as you saw, multiple jets, their direction, the number. Vena contracta, area is going to be important. Circumferential extent, we did not use that in native valves. And I think we'll talk about that. Flow conversions. The jets are frequently eccentric, and this adds to the difficulty of it. So jet height and over LVOT width, which usually we use, really cannot be used because of eccentricity. We talked about the flow reversal, volumetric quantitation, that will be in the outpatient or after the catheterization laboratory encounter. CW Doppler, you saw I put it last because it's probably the least important. It doesn't tell us something directly about severity. It tells us much more about hemodynamics. So let's go through some examples here. This is a poor apposition or under expansion of the valve because of calcification. This is in a TAVR procedure. Although close to where the valve is, you could see a better apposition. This doesn't necessarily mean that you're going to have regurgitation. But in this case, yes, indeed. And you could follow that and see where the regurgitation is, at least from this window, and combine it with a short axis, and you could see where the malapposition of the valve is here on the site of regurgitation. So in this individual, there was one predominant site for the aortic regurgitation after the TAVR. This is a more, mundane when you have meaning multiple areas, tiny little areas of regurgitation with one that is much more prominent, right? And it depends on the long axis, how you cut this short axis view. If you're closer on this side, you're not going to see the aortic valve well, but you're going to emphasize, just like you see in the right lower quadrant, you're going to emphasize where the regurgitation is coming from. It will be much less impressive for you if you cut it through the middle where there isn't really much regurgitation, and that's why this one, which is classic in the middle of the LV outflow tract and aortic annulus, it doesn't look impressive because basically you're missing where the regurgitation is. This is a point about eccentric regurgitation. At times, the eccentricity of the regurgitant jet is quite dramatic. look at this. I mean, this is coming almost perpendicular to the LV outflow tract. So certainly we don't use jet height over, LVOT height. And you see that in the guideline, it is no longer present there. And I think that's very important for us to emphasize. Notice also that because of the eccentricity of the jets, bicolor Doppler, they may appear quite impressive if you're in the wrong plane. So if I'm here at the level of where the valve is and where the leakage is, this is the Vena Contracta of this regurgitant jet. However, if you're further down just below, look what happened. And because of this jet is so eccentric, it appears to the eye that this is severe regurgitation and may not necessarily be. So the issue is, in the next slide, is you really have to scan, do a sweep through the valve, from the top of the valve down to the bottom. And the reason for it is you won't know where the regurgitation is, and certainly you don't want to be fooled where you are below. If you're too high, you're not going to see any regurgitation. If the regurgitation is significant, you may see some flow conversion. So you want to scan it perpendicular to decide where actually the regurgitation is, and you could see it right there. Some of the indices that we use, one, the classic Vena Contracta width. Remember now, this Vena Contracta depends where you are in the circle of this aortic valve. You may or may miss, unless you get it nicely in short axis. But in long axis here, when you see it nicely, you could measure it. Mild AR less than 0.3 centimeter, severe AR greater than 0.6. The challenge, yes, if you have multiple jets, you wonder if you have, 2 moderate jets or above, then it may equal severe, although the data, we don't have really strong data regarding that. Use your judgment. Another index here that has been proposed a few years ago is the circumferential extent, meaning in this circumference, what is the extent of the regurgitation? And I would caution you, don't use it alone, and that's why I say take into account both VC area, which is the area of the Vena Contracta, in addition to the circumferential extent, because at times, although the extent is not too impressive, the area of the regurgitation is much larger. Take these two. These two cases are both moderate. They have a similar area, but one extends much more around the circumference as opposed to this one here. So think about it in two ways. One, the extent, just like this severe one on the right side, as well as how large is this Vena Contracta is. And the criteria, at least that we use now and proposed, is VC area less than 0.1 centimeter squared. And you could even measure that in the catheterization laboratory. It's not very hard. You could do it from 2D or even 3D. Circumferential extent less than 10%, just like your case here. Severe Vena Contracta area greater than 0.3 centimeter squared, or a circumferential extent more than 30% or so. So think about these two parameters together to tell you about severity. And to tell you the truth, this is among the most robust areas because all the others have some issue one way or another. So bicolor Doppler is going to be very important for you. And you can get these by 3D, VC area 1 and VC area 2 from the short axis. So I think be careful about that. Now, certainly from the surface and even from transesophageal echocardiography detection, bicolor Doppler, you really need to know your imaging planes because remember, these focal areas where the regurgitation is, you may or may not see depending on where the plane is, and is the plane bisecting or in line with where the regurgitation is. So this is there for you, to follow. I think we're gonna also provide a PDF for you for these slides, so at least you'll have them in addition to the guideline that is already published. Pressure halftime, CW Doppler, we look at one is the intensity of the jet, right? So beyond mild is very soft and, at times not well defined, but, moderate or severe will have a dense jet. Pressure halftime per se tells us much more about the hemodynamic impact and the relation, what the pressures are within the ventricle, because, a moderate, even mild at times, but moderate regurgitation on a stiff ventricle, acute regurgitation can give you shortness of breath, pulmonary edema, high filling pressure, then the pressure half time will be much shorter. So yes, we use it, but certainly not as impressive as the other parameters that we talked about. And we also use certainly the diastolic flow reversal in the aorta, particularly if it is holodiastolic. It tells us it is at least moderate, and the more impressive the velocity is, most likely, the more regurgitation. And remember also, similar to native aortic regurgitation, if you're detecting this holodiastolic flow reversal further away in the aorta, meaning thoracoabdominal or abdominal aorta, the more impressive the regurgitation is. Now, yes, you could do quantitation, but it is a bit more difficult. And if you're not used to quantitation, even in native valves, this will add a level of complexity to you. So, practice if you're interested. And I think, if you're seeing quite a few of these patients, you really need to have a feel for how to do that. And how we do it is, I'll tell you where to measure the diameters, but in the LV outflow tract goes all the flow in the aorta. And then you need something else to tell you about systemic flow, either mitral or pulmonic or even LV volumes. And, you need to know the pros and cons for each one so you can determine regurgitant volume and regurgitant fraction. And these are the cutoffs, in normal flow, and then abnormal, in lower flow situation, you have to allow for regurgitant volume to be a little less. Regurgitant fraction still stays above 50%. So I alluded to this before. Since now you have a frame of the valve that is rather long, irrespective if it is balloon expandable or self-expanding. This is an outer to outer edge. So you have to match where the pulse sample volume is from the apical window to where your measurement of the diameter is. And if it is just below in the LV outflow tract, below to the valve itself, don't put the pulse sample volume in the barrel of the valve itself, the valve stent itself. Put it just close to the tip. And if you use an inner edge, your pulse sample volume has to be within it. Not much validation for this, to tell you the truth, but I think this is what experience has shown. And your VTI will be larger if you're inside, the barrel of this valve, as opposed to just, before the edges of the valve itself. Too busy for you, but it is in the guideline. And basically this table goes through all the parameters that we just talked about, dividing them into invasive hemodynamics, transthoracic or TEE, the Doppler qualitative parameters, the semi-quantitative parameters of Vena, Contracta, area, and quantitative parameters. EROA using the flow conversions is rarely used in this situation. Actually, if you're going to use EROA, it will be through volumetric flow, because you really can't see well, the PSA radius in those situations. And also, similar to the native valve regurgitation, we have a flow diagram for you to try to help you. It may look daunting at first, but remember first things. You need to know what these specific parameters for mild AR or severe AR. And that's the first question that comes to mind. And how many of those do you have in mind? So if the vena contracta width is small, VC area is small, circumferential extent is also small, everything else lines up. And not all of them may line up, but the majority, I think you feel comfortable that this is mild aortic regurgitation. On the other hand, if you have torrential regurgitation by either, vena contracta area, the circumferential extent similar to the large one I showed you is very large. Pressure half time is also very, very short, tells us about hemodynamic decompensation. Prominent diastolic flow reversal in the descending aorta. Again, all these would line up to severe AR. In between, you'd love to have some quantitation. At times, if you're not able to quantitate, you'll still call it qualitatively, because you have some of each maybe, or they line in between. But if you're able to quantitate, most likely the first two are those that are used the most. EROA is used predominantly in research areas and some laboratories, but less. Bottom line, recommendation to you, if you're really not sure after all what you do of how severe this regurgitation is, please say it in the report. You don't have to say, I don't know anything. You could say, it is difficult to quantitate or assess severity suggests something else. And something else could be a transesophageal echocardiogram or CMR, because really that would be very helpful. And CMR is really very strong in this area, as you know from the native regurgitation. Yes, there is an artifact of the TAVR itself. This is actually a case of valve in valve before and after, so the regurgitation is here paravalvular. So using phase contrast, you could see it here. Flow is quantitated forward as well as backward. And the regurgitant volume and regurgitant fraction is basically from the subtraction of the two. Yes, there is pulmonary flow not accounted for, but I think this is a very robust method to look at regurgitant volume and regurgitant fraction and what happens after an intervention where here you barely have a little aortic regurgitation. I think if you're looking for quantitation, it is probably the best methodology nowadays we have for quantitating the regurgitant volume and regurgitant fraction. Echo certainly can help identify where the leak is, because here you have artifacts, maybe assess the severity, but if you're really not sure and wonder, and if you need a quantitative criteria, you should go for CMR. So that covers TAVR. I think we're going to cover the others also here. So this is mitral valve repair. And edge-to-edge mitral valve repair is approved currently for both primary and secondary mitral regurgitation. And, it is at times not easy to assess how much residual regurgitation you have because of the different shapes and numbers and direction of these jets that are, after an implantation of one or more clips. And the more clips, obviously, you implant, 3 or more, you're going to have, not infrequently significant stenosis. So you're going to look at the gradient in the catheterization laboratory in addition to what is the residual regurgitation. But you could see that at times it can be daunting to assess the regurgitation just by color Doppler alone. So what are the parameters? Well, there are a modification of the usual parameters for native valve regurgitation with an attention here to the mechanism as to is there a position of the prosthesis, or we have not grabbed the leaflets if it is an edge-to-edge repair. Leaflet motion, is there still a flail or a prolapse? Color Doppler, a few things here that are very important. The site, direction, number, vena contracta area, flow convergence, and remember one important thing here is because of the shape of the deformity and what the jet deformity looks like and the flow convergence deformity, you cannot use PISA calculation after edge-to-edge repair to calculate the regurgitant volume or effective regurgitant orifice area. Pulmonary venous flow pattern is very important in the procedure and outside the procedure. As you know, reversal is indicative of severe regurgitation, may not be sensitive, but certainly specific. Mitral inflow pattern, A dominance is very important, meaning mitral inflow, if you have A dominance, you really cannot have severe mitral regurgitation, native or even after repair. Volumetric quantitation, challenging. CW Doppler, qualitative, but also can be helpful. And this is an example here of baseline and after 2 clips of this mitral valve, eccentric jet, quite impressive, vena contracta area in 3D, and I think this is very helpful because you can take care of the eccentricity of these jets. And look what happened to the pulmonary vein at baseline, reversal, predominantly diastolic, and reversal systolic. Notice what happened after these 2 clips. The regurgitant jet is less impressive. Vena flow convergence is less impressive. Vena contracta significantly reduced. And you have almost a resurrection of the systolic wave and normalization of pulmonary venous flow pattern. So let's take an example here. This is a patient with prolapse with significant mitral regurgitation. And this is the case at baseline. And this is a 3D evaluation of it. And you could see how bad the regurgitation is. Prolapse in actually 2 different areas. After deployment of clips in A2P2 as well as A3P3, a significant reduction in the mitral regurgitation severity. And this is one shot of the 2D portion of the regurgitation. And importantly also, that's what you use in the catheterization laboratory, is look at the other supportive variables for you. One, pulmonary venous flow improved significantly. Look what happened to LV stroke volume. The VTI went up from 9 to 14.8. So therefore, stroke volume went up significantly, almost 1.5 or 2 times normal. Spontaneous echo contrast starts developing because of lower flow and less regurgitation. And at times, you may see a reduction in LV ejection fraction when you go in the transgastric view because the mitral regurgitation is decreased and afterload of this ventricle is increased in the aortic pressure. 1 year follow-up, very nice mitral clip, very mild regurgitation, and there was no significant stenosis. So a few things that are outlined in the guideline. One, in color Doppler regarding assessing severity. Yes, you're going to have a challenge because you're going to take a look at, make sure that you're not missing any jets. Take a look at the direction, flow conversions. If it is small, suggest mild, large, significant. Vena contracta width, I think, is among the better ones. And Vena contracta area 3D, I'm talking about 3D, sorry, among the better ones, better defined with TEE, and may be useful after edge-to-edge repair. These are the qualitative ones. And these are the numbers also put in the guideline. Mild, Vena contracta width less than 0.3, severe greater than 0.7, or if you have more than 2 moderate lesions. Same thing, same approach, if you will, for Vena contracta area. And let's go through some examples here, looking at the integration of all the findings. It's not only about color Doppler, integrate as much as you can. Here, you barely have a jet. Systolic velocity is much more prominent than diastolic. Watch the A dominance of the mitral inflow, barely recorded mitral regurgitation. You feel comfortable. This is indeed mild mitral regurgitation. As opposed to this case where I know it's significant, but I may not know exactly how much. The jet is much more impressive. I have systolic flow reversal, but I'm really not sure whether I'm contaminated with the jet itself when I go in the pulmonary vein. I don't have A dominance. I have not too strong, but certainly strong mitral regurgitant jet by CW. And you need to know more. And I think you would probably do a TE if you're going to do something else different, or patient is symptomatic, or this is what you're left with. That really depends on what the clinical situation is. So summarize spectral Doppler, right? CW, we talked about density as well as shape, pulmonary venous flow pattern, mitral inflow pattern. You would use all these. Quantitative parameters, I already mentioned that the ROA and regurgitant volume by PISA, your conventional PISA, really does not work after edge-to-edge repair. And you have to be very careful about, yes, you could use flow conversions qualitatively to help you, but not quantitate a regurgitant volume and effective regurgitant orifice area, because number one, the shape is very deformed. 2, you don't know how much angulation you need to change. Now you have to think about 3D display of this flow conversions, so much more difficult. Volumetric, yes, you could do volumetric, but it can be a problem. Volumetric, I'm talking about from looking at the ventricle itself. Why? Because for this MR, I cannot use pulse Doppler looking at mitral inflow diameter and mitral inflow diameter to look at regurgitant flow and actual flow coming through the mitral valve. So for me to determine volumetric quantitation of regurgitant volume and fraction, I have to trace the ventricle, use a volumetric from the ventricle, and we know what the issue with echocardiography is. Usually foreshortening the ventricle or tracing it, in the trabeculation. So you want to make sure you're not foreshortened and use contrast to enhance your volumetric quantitation, because if you underestimate volumes, diastole and systole, you'll underestimate total stroke volume in the ventricle, and therefore you'll underestimate total regurgitant fraction and regurgitant volume. So you have to be very careful as to when to use it and making sure that you don't have any foreshortening of the ventricle for you to be able to use this quantitative method. Now, we haven't talked much about repair or paravalvular regurgitation because the guideline talks about not only repair of the valve itself, but other issues that you may have. This is a case that we also showed where you have paravalvular regurgitation. You could see anatomically where the abnormality is, a flow reversal and systole in the pulmonary veins, and after occluder is deployed, a nice improvement in the systolic wave compared to the reversal there. And so I think these principles basically also are applicable in this situation. So we showed you basically some of the parameters, and this is again how you're going to put it together. And putting it together, similar to the previous algorithms, is knowing some of these parameters that are compatible with either mild or severe, and these would be specific. If I have a narrow central jet, less than 0.3 vena contracta width, or an area less than 0.2, small or no flow conversions, A dominance, or soft or incomplete jet by CW, meaning everything else is falling into place. Most likely it's going to be MR, mild MR, you don't need to quantitate. On the other extreme, the device is abnormal, the leaflet is flail, the VC width is large, or you have two very large ones. VC area is quite large, greater than 0.4, large flow conversions, central area that is quite large, and pulmonary vein systolic flow reversal. I think you notice that in this, as well as the previous guideline on aortic regurgitation, we don't mention ventricular size and function because, depends what the baseline is. And here you're trying to remedy, a regurgitant lesion of which the ventricle and atrium have had remodeling already. And if you're in between, you may either call it qualitatively, if you will, but for us to quantitate it by echocardiography, you're going to need to look at ventricular size and ejection fraction. And the caveats I just mentioned to you are very important. If you're really serious about it, I would use contrast. Using contrast by itself is not necessarily get you out of the issue, because if the sonographer doesn't get the ventricle well and does less foreshortening, and probably the best would be with 3D echocardiography combined, then you will underestimate the total stroke volume, the regurgitant volume, and the regurgitant fraction. And again, if we're not sure, do something else, get a higher level of investigation. TEE certainly can tell you a lot about mechanism, maybe severity with 3D and all that vena contracta area, because you could do that with. So I think this is very helpful for even more quantitation, CMR and ventricular volumes, et cetera. CMR is certainly very helpful, and this is again a picture from the guideline going through the ventricle itself, a stack of the ventricle. So we call this the indirect approach, because you measure the ventricular output, you relate it to the output in the aorta by phase contrast, and you subtract these volumes to come up with regurgitant volume and regurgitant fraction. Notice also the artifact from, and this is a clip and edge-to-edge repair, and you could see the artifact from it. It may not necessarily interfere a lot with the basal segments, but I think it's important to see that, at least for your information, that you have some interference with the signal from MRI. In the last few minutes, I'm going to talk about the other two remaining ones, which we see less, and I think it's a lot of investigations at this time, particularly for the tricuspid valve, but few words about pulmonic regurgitation after transcatheter pulmonic valve replacement, or TPVR. This is the realm of a lot of congenital heart disease, adult congenital heart disease. And for your knowledge, if you're not aware of, is that most of these valves that are actually indicated clinically, I think there are 2 valves indicated clinically in these situations to remedy severe pulmonic regurgitation, let's say after tetralogy of Fallot repair. is that not infrequently, I think it's a must, to have a stent that basically solidifies this area before implantation of the valve. So you can already surmise that if I use something else, I'm going to have a lot of shadowing. So the transthoracic approach is actually the first line to take a look at this because you're closest to the pulmonic valve itself. And this is mild PR as opposed to severe PR, which with all what we know about native pulmonic regurgitation. Notice that in severe PR, the width is large. There's flow conversions coming back into it. And actually, the worse it is, it can extend into the pulmonary artery, even the branch. By CW, it almost looks like a sine wave where almost no pressure is towards the end of diastole. And you may have premature, even opening of the pulmonic valve with early termination of flow at times. Then signal as opposed to a soft signal here. So another thing which is important, I think, is TEE, in contrast to all other valves, certainly the aortic and mitral, has a lot of limitations. So from our adult congenital heart disease specialists, TEE is really not your second line. If you're really not sure as to what's going on there, a CMR would be the more robust one to quantitate not only the regurgitant fraction, regurgitant severity, but also certainly for timing of any other interventions, quantitation of the right ventricular adaptation to the volume load, be it the right ventricular volumes or ejection fraction. For the guideline itself, we have few parameters. I think most of them are taken from the native regurgitation with some adaptation to the TPVR from data in some of the trials. Jet width in relation to the pulmonary annulus, because most of them are much less eccentric as opposed to, remember, TAVR is much more paravalvular as opposed to valvular here. Site of diastolic flow reversal in the PA or conduit, right? It extends into the PA branches and severe PR. Velocity contour and density. You can have early termination of diastolic flow. Remember, this is not necessarily specific, because if you have a lot of diastolic dysfunction or you have significant tricuspid regurgitation, you may have equalization of pressures. So these termination of diastolic flow has to be put together with the regurgitation that you see yourself. PR pressure half time along the same line as what I just talked about. A regurgitant fraction, if you can quantitate it, greater than 40%. We don't talk much about CT, but I wanted to mention it here because you have a stent that is put together before the valve, and at times there is a fracture of the stent that is causing part of the issue with pulmonic regurgitation. So our adult congenital heart disease experts, do that from time to time depending on what the etiology. But again, as mentioned earlier, CMR is very important in those situations. Yes, there is an artifact, as you could see here on the left side, but the phase contrast is taken a little higher where you have less interference with this stent artifact, or you could use it just below it and look at in this severe regurgitation, almost the biphasic flow of pulmonic regurgitation. Last but not least, I think tricuspid regurgitation. It is a new frontier. It is a rapidly evolving field with a lot of enthusiasm as to what to do with tricuspid regurgitation, the significant regurgitation. Currently, there's no catheter device that is approved yet for this indication, although you see early data with edge-to-edge repair, but you could see a lot of development, and I think you should stay attuned to the various ways of repairing or replacing a tricuspid valve. As you know well, the vast majority of these regurgitations are secondary as opposed to primary tricuspid regurgitation, either pulmonary hypertension or RV dysfunction, whatever it is. And the mechanism of this annulus dilatation and malopposition of the valve is much more in this direction, lateral, if you will, expansion of the annulus. And this is an example of severe regurgitation. We have issues, I think, quantitation overall. there is a lack of well-validated quantitative parameters for TR severity. We can propose many, and actually, if you look at the latest, at a recent issue of JACC, Dr. Becky Hahn and myself and several other authors, looked at the issue of TR and what are some of the methods that are proposed. We have still issues, honestly, with them. Reproducibility at times is an issue. We need to have a more robust way of looking at quantitation. Yes, we have several semi-quantitative techniques. The other issue is a very wide range of severe TR. In contrast to AR and MR, people can live without a tricuspid valve. So at times, you see a tricuspid valve that has no coaptation whatsoever and laminar flow through the valve. Yes, it is severe. And, there have been proposals as to, expanding the grading of severity of TR because you can live with wide open TR or torrential TR. Unfortunately, I think, yes, patients may get a little better, but from early data is that if you're left with severe TR, although you've improved it from much higher to a lower, the prognosis is still not as good, most likely conceivably because of the underlying disease that has caused the tricuspid regurgitation to start with. So there's a lot of work actually currently in the tricuspid regurgitation and valve arena. What we proposed in the guideline is a bit of a modification of what native tricuspid regurgitation assessment is, including the qualitative jet area if it is central. And remember, if you put an edge-to-edge repair on it, again, the same issues occur similar to mitral, multiple jets, eccentric jets. You can't use quantitative parameters of the ROA after implantation. So saying there are issues there, but we use semi-quantitative criteria, the Vena contracta width, Pisa radius, tricuspid inflow, few other things. And this is an example here that we also included in the manuscript. Significant reduction in color flow from baseline to edge after edge-to-edge repair, reduction in area, significantly there, reduction in the anatomic malcoaptation, because not infrequently you see that because patients are referred quite late in their clinical presentation, and improvement in hepatic flow. So that's what I attempted to do for you. Hopefully you found this helpful. A tour of the guidelines with some illustration of what went behind the scenes, some of the thoughts behind the scene regarding this new field of catheter-based intervention. One thing I would like to refer you to, and hopefully you'll have a chance to take a look at, is case studies on valve regurgitation, and this is the website. The website actually includes native valve regurgitation as well as this new field. I have to admit that we have not had the chance yet to put one or two cases for you, but hopefully within the next 6 months, we'll have some of these cases that we just talked about to add to the complement of close to 15 other cases already on the website evaluating aortic, mitral, tricuspid, and pulmonic regurgitation. And last but not least, I think there will be a poster that I think hopefully you will like, detailing the aortic interventions and the mitral interventions with an illustration of some of the things that you saw today, as well as the algorithm. And to my knowledge, I think it will be revealed in 2 weeks or so at the American Society of Echocardiography. So get your poster, and there will be pocket guides, and I'm pretty sure the app will be updated at AASE. So hopefully we'll see you there, and I do hope that you've enjoyed this webinar. Liz, back to you.
Thank you, Dr. Zoghbi. It looks like we have several questions here. We have about 10 minutes left in the webinar, so why don't you take a few of those questions to answer, and then any questions that aren't answered, Dr. Zoghbi will answer them, and they will be emailed to you guys after the fact.
Gladly, Liz. We will do. One question here: how should we assess aortic insufficiency after in valve TAVR? I think it will be similar to what what we've done today. Remember, it may be also in different areas of the circumference. Usually, the nice thing is you have a tight valve. I don't know if it is fractured or not before in the valve and valve, but I really think it poses similar challenges to what you saw after TAVR. I think you would have a similar approach, also a similar approach to a plugging of a perivalvular leak in an aortic situation. Another question says, practically LVOT VTI is measured a little below the aortic valve on transthoracic echocardiography. Measuring LVOT diameter in TE is sometimes very difficult. Is it advisable to use TE-derived LVOT diameter for consistent post-TAVR aortic valve? Basically, the issue is, where do you measure the diameter? And as I showed you, okay, you can't really do a TEE to measure the LV outflow diameter. And you have two options at this stage of the game, depending where you see the valve positioned in the LV outflow tract. If it is quite a bit in the LV outflow tract, I would use an inner edge and put pulse sample volume inside the funnel before the aortic valve and clicks, etc. If it is where you can measure an LVOT itself, not dangling too much in it, I would use the other approach. Can you please clarify the definition of edge-to-edge valve repair? Is this percutaneous valve repair replace? Edge-to-edge is the modified Alfieri, right? Is a clipping of the valve. That's edge-to-edge nowadays called. That's the generic name, if you will, for all of them, because there are two manufacturers nowadays having them. And so this is what it is. Also, many of these would, in the new investigations of what you do to an annulus or what you do for a total valve replacement, many of these criteria we talked about would apply. Is E dominance in mitral inflow pattern must mean severe MR, specifically if there is eccentric jet? It's hard to say because E dominance, as opposed to A dominance, is not specific. Because you can have E dominance because of just high pressure, like in heart failure, right? So it depends what the load is. You can have at times some E dominance if you've created much more stenosis. So since it is much more load dependent, it is one of the factors. You're going to use it less if the heart is dysfunctional, but I would use the other parameters much more. Let's see, what else here? How do you describe in a report MR after edge-to-edge repair? Just like we talked about. Basically, you have to, if you can tell how many jets do you have, how severe it is, obviously you have to say that there is a device, alert the physician, whoever is ordering this echocardiogram, because it's no longer only cardiologist, and describe the severity, the pulmonary hypertension, ventricular function. You have to describe the whole thing. Great. Please explain why the mitral valve annulus can't be used for volumetric assessment after mitral valve edge-to-edge repair. I think that's a good question, because meaning why I can't use the annulus after I have a mitral valve edge-to-edge repair. At times there is flow conversions actually coming in because of the mild stenosis, or at times moderate stenosis. So you have acceleration of flow going in. Two, at times, because of the clip itself, the plane of the mitral valve opening is very close to the annulus itself, which goes along with point number one I just mentioned. So it becomes, much more difficult, if you will, from an accuracy point of view to do that. I mean, if you have a valve that is so tented that I can see the annulus really well, I don't see flow acceleration conceivably, you could use that, but it has not been our experience. When we used MRI to calculate regurgitant volume fraction, is the same cutoff as TEE. Yes, I think I say yes, and that's what we proposed with our collaboration from SCMR and our specialist in MRI. And the reason for it, at this stage of the game, we don't have different, cutoffs or large data, particularly in this field, after repair or replacement, to say that they are different. They may be different, and actually some data is telling us that there may be some difference depending on the technology, because you may have some underestimation or overestimation and errors that come into play. So, but at this stage of the game, yes, they're the same cutoffs. Any input on the valve of hepatic venous Doppler on intra-post-procedural imaging for transcatheter tricuspid valve repair replacement for tricuspid regurgitation? It is an issue. So this is tricuspid valve. Each center is doing some tricuspid valve, repair, either through an IRB or some extension of other indications. Hepatic venous flow, unless you reduce significantly the regurgitation, the systolic reversal of hepatic venous flow stays abnormal. Now, how do you get it? If you're in the OR setting or cath lab setting, you could turn your TE towards the hepatic veins and get aligned with them, so you can get that. If you're doing a transthoracic approach, you could do it in the usual way, but use it as aligned, usually in hepatic vein, that I think would be easier for you. How about 3D LVOT reconstruction of the LVOT diameter? I think 3D reconstruction of the LVOT is an acceptable way. And the question is, where do you want it and when do you need it? I think, I don't know about your centers, but most centers use pre-op CT and do the whole thing with CT, unless you don't have CT or unless your preference is to do the examination with echo and 3D TE. Yes, it can be used. Be careful on once you have a valve in there, some of the shadowing and things that we just talked about, for you to be able to measure an LVOT. 3D LVOT measurement on average 17% larger, more consistent with CT scan. That is correct. I think it's probably a little more consistent because, be it 3D or 2D, you're going to have some lateral resolution issues and at times some attenuation depending where you're getting the 3D TE from. It is similar to a 2D point of view, right? With maybe better localization as where you are in the LVOT, but the same still applies to the other measurements of LV outflow tract. Liz, I think we're at the hour, and I think we've answered most of the questions to the best of my knowledge.